Genetic cardiac conditions may be difficult to diagnose. However, guidelines are actually now recommending broader testing. Plus, in recent years, cardiac genetic testing has been expanding, and this is exemplified by Invitae, for example, a company specializing in genetic testing for hereditary disorders. And to talk about this whole issue, we've got a cover story coming up in CardioSource World News on the general topic of genetics here. And I'm with Colleen Caleshu, who is an MS LCGC. She is the head genetic counselor in the Stanford Center for Inherited Cardiovascular Disease and a clinical assistant professor in medical genetics at Stanford University. Things are expanding rapidly, aren't they, in this field?
Yeah, they are really. I mean, we've had really rapid advances in our understanding of inherited heart conditions, as well as technological advances that have expanded our ability to look at more genes and look at them faster and look at them cheaper.
Where are we right now in terms of how many genes we can look at, and how important is this whole topic?
We can look at all of the genes if that's the right thing to do. I think one of the things that's really important now that we have this really powerful, fast next generation sequencing technology is to be judicious about, in a given situation, which genes do we need to look at, who do we need to look at them on, and how will it affect the care of the patient and the family. And that really gets at how important it is. And I would say it's pretty important. And the fact that multiple cardiology professional societies from around the world are now recommending genetic testing for inherited heart conditions and unexplained sudden death really shows you how important it is. And the importance comes primarily in the care of the healthy relatives who are living in uncertainty and don't know whether or not they could have the familial heart condition.
I mean, at ESC in London just a couple of months ago, we were there, and they have a new ventricular arrhythmias and prevention of sudden cardiac death guideline. And for the first time, their guidelines have incorporated the concept proposed by several consensus documents that DNA analysis should be fundamental component of postmortem assessment in any young sudden death victim. I mean, that's a change.
It's a big change, and it's really great to see for folks like me who work in centers for inherited cardiovascular disease and are on the front lines caring for these families who have lost a healthy, seemingly healthy young family member suddenly, traumatically. And we see what they go through, the uncertainty that they deal with, their intense desire to prevent further sudden deaths in their family. It's really great to see professional societies getting behind the need for genetic testing in those families.
I mean, the two consensus documents they were referring to, those are from the United States, correct?
Yes, from the Heart Rhythm Society, although they did have some contribution from both Asian and European colleagues.
Where are we right now in terms of who should get tested?
When it comes to sudden death, any young unexplained sudden death, or it's not always a sudden death that's clearly cardiac. Sometimes it's an unexplained drowning. Sometimes it's an unexplained single vehicle accident, in great driving conditions. Or when the autopsy shows clear evidence of an inherited heart condition. It's really critical in all of those cases that the right sample be saved for genetic testing. Not all samples are good for DNA. And it's so important because sometimes the genetic testing is the only tool that we have to be able to figure out which family members are at risk for sudden death and need care, and which family members can be reassured about themselves and their children.
In terms of young, how is it defined?
No, that's a great question. It's defined differently by different people in different settings. I think under 40, under 50 is a good rule of thumb. Of course, there's a sensitivity specificity trade-off. But if you're looking at a really thorough, good cardiac autopsy, there's no coronary artery disease, there's no signs of cardiomyopathy, and the story fits for a cardiac arrest that someone didn't survive, I think even if they're older, it's worth doing. In these diseases, we can certainly have sudden death across the lifespan. It's not only in youth.
And I think it's important to note, it was Invitae who is just recently, they expanded, I think, another 30 genes. Mm-hmm. And now there's a total of more than 190 genes that you can analyze. Should you do all 190? How do you decide what panel?
Great question. So deciding what panel, and by that, which set of genes, is a really critical part of a cardiovascular genetics evaluation that involves, a genetic counselor with expertise in cardiology, a cardiologist with expertise in inherited heart disease, And it's really guided by specifically what we're seeing in the family, not just the individual, but the whole family. In the case of unexplained sudden death, if the autopsy is normal, the most likely thing is that it was an inherited arrhythmia, something like long QT syndrome or Brugada or CPVT. So you want to be including those genes. But many of us will also think about including cardiomyopathy genes. Could this be somebody who had a hypertrophic cardiomyopathy variant or LMNA variant where the arrhythmia was really the very first presentation of their cardiomyopathic disease? So that's with sudden death. Then in the clinic, with living individuals who have inherited heart disease, it's largely guided by what their diagnosis is, or in cases where we're unsure of the diagnosis, what our differential diagnosis is.
Does it also matter depending on their heredity in terms of whether they are African American, whether they are European, whether they are what part of the world their family comes from?
For the most part, no. And that is true in other genetic conditions. There are many genetic conditions where certain diseases are more prevalent in certain groups. We see that a little bit in cardiology. In familial hypercholesterolemia, there are variants that are more common in French Canadians, in South African Jews. In hypertrophic cardiomyopathy, there are some variants that are more common in certain European populations. But none of it is in any way that would really shift what test you would order. You still want to be looking at the key genes for that disease in that individual.
So where are we in terms of cardiologists actually going to know which patient to send to a geneticist or to say, after the fact, why aren't they sending them to me?
Yeah, we've actually come a long way in that. There are recommendations now from multiple professional societies that families with inherited heart conditions or unexplained sudden death be seen by an expert center for inherited cardiovascular disease. And genetic counselors and cardiologists specialized in inherited disease are key parts of that center. So there's really, it's a recommendation in the Heart Rhythm Society expert consensus. It's actually a class 1 recommendation. So these families really should be referred to people who have that depth of expertise. And that's in part because these diseases are rare, they're complex. You have to think about the whole family, not just the individual in front of you. And genetic test, both selection and interpretation, is a highly specialized skill. Genetic tests aren't black and white. They're not just clearly abnormal, normal. You really have to be careful in how you interpret the results that you get from a genetic test and how you then apply them to the care of an individual and a family.
And you don't necessarily go out and do all 190 genes at once.
Exactly. So, and the reason why you don't, in most cases, is because the more genes you add to your panel, your specificity goes down.
Right.
You're going to get inconclusive results that you may, interpret inappropriately, or your lab may, just because it's a hard thing to do. So, picking the right panel is really important, and that's a big part of my job as a genetic counselor, whether it's in sudden death or an inherited heart disease.
Well, please make sure that you see our cover story in Cardiology World News that talks about some of these issues. And also, please, because we're at the AHA meeting in 2015, look around. We have a lot of coverage from this particular meeting also at Cardiology World News, where I am the executive editor, Rick McGuire.